The affected upper limb is positioned by an assistant at a 90-degree abduction and external rotation on a hand table. With the surgical ball placed underneath the elbow, a trocar and a switchboard are then separately introduced through the two portals to spread subcutaneous soft tissues. With the preliminary subcutaneous space created, the scope is inserted from the proximal portal. Meanwhile, a shaver or radiofrequency device is introduced through the distal portal as the working portal. The working space is then expanded distally, laterally, and proximally, and the tissue anterior to the medial intermuscular membrane is resected. The medial epicondyle is localized, and the cubital tunnel retinaculum is cut off from the posterior inferior corner of the medial epicondyle to expose the underlying ulnar nerve. Subsequently, resection of the intermuscular membrane is performed proximally. The two portals are switched, and under reeling from the distal portal, any remnant intermuscular membrane is completely cleared off from both the medial epicondyle and the medial rim of the distal humerus. The two portals are switched again. When viewing from the proximal portal, tissue around the ulnar nerve and any obstacle such as the arcade of Strodder's for ulnar nerve transportation are resected. Then the proximal segment of the ulnar nerve is dissected free from its bed. The distal segment of the ulnar nerve remains covered by the flexor carpi ulnaris muscle fascia. Therefore, the portals are switched again. When viewing from the distal portal, the flexor carpi ulnaris muscle fascia is incised distal to the medial epicondyle, and the scope is switched into the proximal portal. The flexor carpi ulnaris muscle fascia is released more distally. The residual cubital tunnel retinaculum is cleared from the ulnar nerve. A half centimeter portal is created 3 cm lateral to the medial epicondyle as the retracting lateral portal. A 2 mm rubber tube is inserted from the distal portal and wrapped around the ulnar nerve, with its two ends retrieved from the lateral retracting portal. By gently retracting the rubber tube, the ulnar nerve is mobilized into the previously developed subcutaneous space anterolateral to the medial epicondyle. The distal segment of the ulnar nerve is released from its bed using the punch or radiofrequency, and the humeral head of the flexor carpi ulnaris muscle fascia anterior to the ulnar nerve is resected distally to prevent any block for transportation. An anchor is transcutaneously implanted into the medial epicondyle, and its sutures are then retrieved around the insertion incision. Subsequently, the anchor sutures are tied to secure the skin onto the epicondyle in order to prevent subluxation of the nerve back to its natural position. After rechecking the newly course of ulnar nerve, the 2 mm rubber tube is removed and all portal incisions are closed.